So we tend to keep coming back to this topic, but I think it's an important one, and so which is why we keep coming back to it really. So next we've got a debate, and so the statement is women with a BMI of over 50 and endometrial cancer should be managed conservatively. So just before we bring our speakers to the stage, could I have a show of hands for those people that think if you've got a BMI of over 50, really you should be looking at conservative management? Okay, and for against the motion, show of hands. Okay, so I reckon about a 50-50 split. So you've got a good debate on your hands here. So we've got Mr. Thomas Ind and Nithya. I'm terrible with your surname. Ratnafellow. And it's a particularly interesting debate because we've got the president of the BGCS versus the secretary of the BGCS. Sorry, treasurer of the BGCS. So. A very exciting debate to come. Thank you. Would you like to both come to the stage? Are you starting? So Nithya's going to start. Thanks. Tom, do you want to grab a seat up here?
Thanks, Amy, for arranging a very stimulating day and hopefully for a stimulating debate. My name's Nithya Ratnavellu, and I'm speaking in favour of the motion that women with a BMI more than 50 and endometrial cancer should be managed conservatively. So why are we still discussing this in 2025? Well, it's because the issue is obesity leads to an increase in the prevalence of cancer and endometrial cancer fourfold, and also the incidence of obesity is rising. We know that more and more young women are becoming obese, but not only just obese, morbidly obese. We see more morbid obesity in young women than we do in the elderly. And 5% of women with endometrial cancer are premenopausal. What we do know about women who are obese and have endometrial cancer is that they have a more favourable outcome, and that's because the cancer tends to be low-grade, endometrioid with no LVSI, early myometrial invasion, so they have a good prognosis. But because of the fact that 25% of them are premenopausal, we do have this duty of care, 5% are premenopausal, we have a duty of care that we do offer them non-surgical options. So why obesity and endometrial cancer? The best education I ever saw for the public was on a bus stop billboard, and it basically just said obesity causes cancer, because patients don't realise that it's the obesity that's causing it. So actually there's a teachable moment within this, that actually it wasn't something that happened to you, it's actually something that we can correct. With obesity, it's not only hyper-estrogenic and hyperinsulinemic, but it's also inflammatory, and there's reduced apoptosis, and therefore it becomes more tumorigenic. So essentially, we can show the science behind it. In 2006, Richard Barakat group from GOG looked at almost 400 patients with endometrial cancer who are obese, and they found that, well, obesity, unsurprisingly, increases mortality, but also women with endometrial cancer were more likely to die from non-cancer related disease. And in the first 12 months following diagnosis of endometrial cancer, it was more likely to be a cardiovascular event that killed them than the cancer. In addition, in terms of treatment, they were more likely to have cutaneous toxicity with radiotherapy. So some murmurings there about, is surgery the right thing? So in my debate today, I'm going to propose to you a number of pieces of evidence which will hopefully support these 4 pillars behind my claim that women should be managed conservatively. And the first is that surgery causes risk. The second is that surgery in women who are obese is suboptimal. Thirdly, that non-surgical options exist. And finally, that non-surgical options may prolong life. Okay. So my esteemed colleague and the president of our society, this charming gentleman who is a prolific robotic surgeon and very experienced, will tell you quite simply, I'm certain, that surgery cures. And it does. But we are here today because it's not just about can we do it? We can do it. And in the hands of expert robotic surgeons, you can definitely do it. But is it the right thing to do? A Japanese study looking at exactly this, the impact of robotic surgery in women with early stage endometrial cancer, showed that although in women with BMI more than 30, there was no difference really in operative blood loss or operative time, complication rates, or even 5-year survival between those that had a BMI less than 30 and those that had a BMI more than 30. But actually, if you had a BMI more than 35, you had higher post-op infections, and we know this. We can predict this is going to happen to our patients because they're more likely to have diabetes and other comorbidities. But there were also increased treatment costs, and that's not related just to the fact that they're obese, but all of the other things around it, anaesthetic, the complications in terms of infections, and they're more likely to develop new lifestyle-related diseases following surgery as well, or be diagnosed with them. We understand that treatment outcomes in the morbidly obese, this is the Cleveland Clinic study of almost 1,800 patients, found that patients with a what was known as class 3 obesity or BMI more than 40 are more likely to be significantly younger. So that goes back to the title of this debate was BMI more than 50, and a lot of the studies here use 35 or 40 as cutoffs, because really anything more than that, we're talking about morbid obesity, we're talking about patients who are likely to be young, and therefore we need to consider non-surgical options. And they found that actually in obese patients, it was those favourable prognostic factors, so low grade, low stage, no LVSI. What they also found was that if you were obese and you had surgery, you were more likely to have had that suboptimal surgery I'm talking about, less lymphadenectomy, if you had a BMI more than 40. I certainly know from my own experience that it's a challenge to get through a minimal access case in a patient who's morbidly obese, and I'm more likely to try and be safe. This was an SGO survey in 2023 of practices amongst gynae-oncologists and asked them specifically about women with BMI more than 40. They had an almost 20% response rate, so 255 respondents, and 71.8% of them offered non-surgical management to women with BMI more than 40. So that's the vast majority. So I'm wondering why we're having this debate, because people are already doing it. And if you're honest, you will be thinking that way as well. What they'd like to do prior to offering non-surgical management was hysteroscopy, DNC, and an MRI, just to ensure that it wasn't advanced stage or deep myometrial invasion. There is this graph here which shows a kind of almost a trend of, what is your cutoff point? We like to say, what is the cutoff for offering surgery? And as you can see, as the BMI increases, the cutoff, the number of respondents saying they would definitely offer non-surgical management increases. What was also found in this survey was that actually only 57% of the responders did not consider molecular markers and molecular profiling in their consultation, so they didn't look at that. And 70% didn't even consider whether they were ER or PR positive either. The main reasons in this survey for not offering non-surgical management was concerns about disease persistence. So that was a good survey. Then there was a further survey, this was in 2023 as well. Sorry, beg your pardon, this was the last table from that same survey. This was about what they would actually offer. So there was Mirena-Coil as the main treatment method. And as you can see, it's not just a one-size-fits-all, so we don't tend to say we'll throw Mirena-Coil in and leave it at that. Some of them offered combination treatment with Mirena-Coil and progestogens, and also you can see a huge number offering some bariatric referral as well. But you see the variation there in practice about when to biopsy, when to survey, what to use, ultrasound scan, etc. So this is why we are having the debate, is because actually although we broadly do feel that there are risks with surgery and there are probably benefits with non-surgical management, we don't have very clear guidelines of how, when, what and where. Same year, ESGO survey, and this was about the adherence to the ESGO guidelines. And this was from the Frank-Again group of 11 institutes with almost 2,500 patients involved. So they looked at practice, and they looked at the practices of the outcomes of those patients versus the guidelines. So it was really quite well thought out. And what they found that with regards to optimal surgical management, pelvic and periaortic lymph node sampling or staging, and adjuvant treatment, that if you were morbidly obese, so that's 30% of morbidly obese patients had optimal surgical management compared to the obese being between 30 and 40 BMI, 44% optimal surgical management compared to 48%. Pelvic node staging for the low risk and intermediate risk endometrial cancers was only performed in 7% of the morbidly obese, compared to 57% in the obese but not morbidly obese group compared to normal, overweight should I say. The same with periaortic nodes. Conversely, though, for adjuvant treatment, there was a high proportion of adjuvant treatment performed for the morbidly obese, and I wonder if that was because they were having suboptimal nodal staging. So in an MDT, there was a bigger steer towards offering radiotherapy. In the discussion here, what they found, and what's been echoed in many other papers, is that embarrassingly, what you would find in an MDT is that you've maybe got an obese patient, you've done a hysterectomy, and you've removed some fatty yellow tissue. Empty package syndrome. So in 8.2%, those nodal packages are empty. And that's suboptimal surgery. They're also, in this group, found to be higher post-op complications, particularly if you had to have open surgery. And they concluded the same thing that I mentioned earlier, that actually these women who are obese have more favourable outcomes because they're endometrioid, they're low risk, and they're no AVSI. We've got alternatives, so we know this. Medroxyprogesterone acetate, megestrol acetate, and the Mirena coil all have really good regression rates. And with correct counselling, patient selection, and discussion, and that kind of treatable, teachable moment, these are acceptable alternatives. And you can use them alone, you can use them in combination. The FEM trial, Obermeyer's group, looked at in obese patients whether weight loss, metformin, or Mirena coil were effective strategies for complete pathological response. And at 6 months, they found that in those with a BMI more than 30, at 6 months, just weight loss alone, 67% had regression. With Mirena coil alone, 61%, and with metformin, 57%. But as I said, you don't tend to do these things in isolation. We tend to do a combination approach. But the evidence is pointing to us that there are alternate strategies which may be better for patients who are obese. And I put this up here because if you don't remember, too long ago, we had the COVID pandemic, and national and international guidelines at the time were all saying, if you have a patient with a low-risk endometrial cancer, don't operate. Please use hormones. So, as I've just said, there's a lot of evidence, there's already been guidelines, and there's a lot of previous experience that we have in this room for not operating. And then we talk about those younger women and fertility. We know that a lot of these patients who are obese have anovulatory cycles, if any at all. And with a combination approach, pregnancy rates can increase. With oral progesterones alone, the live birth rate improves. So we've got this chance of actually offering patients that ability to try and conceive and have their families, particularly as women are waiting later and later in life before they have their babies. There are guidelines regarding fertility-preserving surgery for women with endometrial cancer, and I put this in here because, as I said, those women who are obese tend to be younger and younger, and the more morbidly obese tend to be the youngest. So combination treatment works really well for live birth rate, as well as complete response. And what they've recommended here is considering, let's say there's a polyp, resecting it, and then giving them an oral progestin as well as a Mirena coil. What they've also recommended is that you allow maybe a maximum of 15 months for a complete response, but assess it at 6 months to see whether there's been any change at all. And they strongly recommend weight control. They do recommend considering the molecular profiles. And so we do actually know that poly and p53 wild type patients have the best response to fertility-sparing treatments, whereas MMR deficient and p53 aberrant patients have the poorest response, and perhaps should be p53 aberrant should be perhaps considered as a contraindication to fertility-preserving management of endometrial cancer. So, there's emerging data that basically shows that weight loss can also impact endometrial health and downregulates pro-oncogenic signaling pathways. So we know that weight loss acts synergistically with progestins, restores endometrial health, boosts fertility, and improves fitness for future proposed surgery. Something that we worked on a lot in the Northeast, where we've got a lot of obesity, is risk reduction bariatric treatment for endometrial cancer in conjunction with hormones. I'll talk to you a bit about treatment with bariatrics and then survivorship. So there's also potential benefit of improving fertility, reproductive outcomes, but also reducing the risk of recurrence. Okay, so this study from Emma Crosby's group in Manchester looked at women who were diagnosed with endometrial cancer, were given a Mirena coil, and were then offered bariatric surgery. And a third of them said, yes, please, we'll have that. Those who didn't want it were worried about bingo wings. There was a 23% total body weight loss on progestins, And of the 2/3 who were in the diet only, decided not to have the bariatric surgery, they lost about, well, a quarter of them lost about 13% of total body weight. So you can see that actually having some bariatric intervention worked better. Women overall, the women who lost more than 10% of their total body weight were more likely to respond to the Mirena coil. So things are working synergistically: hormones, bariatric surgery, or weight loss, should I say. In the Northeast, we certainly have established an expedited pathway for referral to bariatric surgery with the standard criteria as you would for conservative management of endometrial cancer. And this is what the flowchart looks like. Just one slide about radiotherapy, because it is an alternative as well for those patients who perhaps are not trying to preserve fertility but are not suitable or not willing to have surgery, with a good 63% response on pathology. I'll finish up by talking about our guidelines. We've got the BGCS guidelines, which clearly states that if you're unfit, you could consider vaginal hysterectomy or radiotherapy or brachytherapy, hormones or resection. And they even mention the role of GnRH analogues, and they've given some indication regarding when to survey. ESGO guidelines say the same thing, basically supporting exactly the same thing that the BGCS have said. Combination treatments are strongly recommended. So to conclude, we have a duty of care to our obese patients, to discuss non-surgical options with them, to think about their holistic needs and treat them as individuals. And I would definitely suggest that we do this in a stepwise fashion. And I'll leave you with this final thought. Thank you.
Thank you very much. I think what we'll do is we'll do questions at the end, because it might be some questions are for both speakers. So we'll let Thomas speak next.
Thank you. First of all, before I start anything, thank you, Amy. You do make a really good meeting, and whenever I come to this meeting, I feel that it's such a good bunch of people here, and I think it's one of our stronger constituencies. I think Amy does a huge amount for this society, and I think this meeting today really says it, and someone's got to shout it out, and as I'm going to have to leave early, I'm going to say it now. Thank you. Are my slides going to show? Do I have to press a special button, or because they're showing up here? There we go. Women with a BMI of over 50 and endometrial cancer should be managed conservatively, and I'm speaking against this. I'm sure you realise that as a society we've taken great care to address the subject of bullying and harassment. And I was very, very worried when Amy gave this topic to Nithya, because quite frankly, I thought it was unfair to give her something that she couldn't win. Because we all know it's wrong. I have disclosures, not many. So I thought, for a minute, I thought about this horrible deed that she'd dished out on my friend. And then I realised that Nithya's quite clever. We all know Nithya the magician. She can pull anything out of a hat. And God did she try earlier on. But we're not going to be fooled. So let me just look at the title of the debate and why it was so loaded against her. First of all, we used the word should. Should is a verb which, according to the Oxford English Dictionary, can either mean used indicating obligation, duty, or correctness. So the right thing to do would be offering conservative management to all these women. Or used to indicate what is probable. It should be a good day tomorrow. I can't think of any reason, any definition of the word should, which would mean conservative management of these patients. And I thought, just in case there was a bit of dirtiness, I would define conservative management. And luckily, Nithya didn't try to define it wrong. But it's not something such as major surgery or treatment. So if you're going to advocate vaginal hysterectomy with conservation of ovaries, that's not conservative management. If you're going to advocate chemotherapy or radiotherapy, we wouldn't call that conservative management either. Most people would consider what Nithya described, a combination of progesterones in all sorts of way and some lifestyle changes, for 2% of people with a BMI of over 40 who can actually lose weight. because it doesn't work. So really we're comparing this conservative management with standard of care. Okay, we're all going to show the same slides, as always happens in the debates, and we're going to interpret them slightly differently. The standard of care is listed in the British Gynecological Cancer Society guidelines. And if you were to write these guidelines or be part of making them, you'd be completely bought into what they say, wouldn't you? And that's why a certain Nithya Ratnavelu is going to be bought into them. We should, according to these guidelines, offer conventional treatment, which is normally hysterectomy, plus or minus lymph node assessment, radiotherapy, chemotherapy. And if they're not suitable, it doesn't say what makes you not suitable. It says if you're not suitable, well, then you can consider radiotherapy. I didn't see the bit about hormone therapy, but I accept that a lot of people do it, and maybe I have to go back and look at it and retract. But I don't mind retracting because, quite frankly, I'm so easily going to win this debate. But it's not going to be a problem. Again, the European guidelines say that surgery is the standard of care. The NCCN guidelines say that surgery is the standard of care. But I completely accept that this is a difficult group of people. It is a difficult group of people. First of all, they're more likely to have endometrial cancer. Well, we all know that. We had a nice little diagram that we show the medical students, aromatization of testosterone and androstenedione to estrone, inhibition of sex hormone binding globulin, and therefore more circulating estrogens. Yeah, more likely to have endometrial cancer. And I thought that Nithya would say that they're more likely to have type 1 cancers, and she did. They're so much better than type 2 cancers, and therefore these women have a much lower risk of disease. I'm going to dispute that. They're slow growing. They're not really a problem. They have a better prognosis. Well, type 1s are slower growing and do have a better prognosis. I don't deny that. But these women, oh dear, you don't want to operate on them because they've got diabetes and hypertension and depression and sleep apnea and other problems too. So I thought she would say these are very, very minor cancers, don't really need to worry about them, and they've got comorbidity and we don't want to hurt them. Well, we know about obesity. There are whole textbooks about obesity in gynecology, if I can get this to work. This is Tahir Mahmood's textbook. It's in its second edition. I know it quite well because I wrote a chapter in it. And we know a lot about obesity, not just specific to endometrial cancer. We know that women with a high BMI aren't just more likely to get endometrial cancer, but they're likely to present later. And more importantly, whatever problem they have, they're much more likely to be non-compliant with treatment. So you can talk about surgery being inadequate in these people, but of course the conservative management's going to be inadequate because they've got to turn up for their follow-up, they've got to take their progesterones, and they are non-compliant. Contrary to what has been stated, there is a large meta-analysis, systematic review of studies that show stage for stage, grade for grade, women who are obese and have endometrial cancer have a higher rate of recurrence and a higher mortality. The higher rate of recurrence is, I accept, lower than the higher rate for mortality because they die of other things, but their cancers have a worse prognosis stage for stage. That's a meta-analysis, it's not a one-off paper that I've trawled out. What you need is regular follow-up in someone who doesn't comply. You need to take into account the side effects of progesterone, which we all know include bowel symptoms, depression, and of course continued bleeding abnormalities. And do you know what? At the end of it, the recommendation for conservative management is have a hysterectomy. That's the end of your conservative management. And we quoted COVID, and we applied those rules, I think, for 9 weeks, when we thought that people couldn't actually get into the anaesthetic room and we were having to prioritise people. That wasn't justification for allowing people to have no treatment or give a bit of progesterones. So, what's the latest meta-analysis on this, conservative treatment? Well, the latest meta-analysis on conservative treatment was from Adiola Alatum. It was published just over a year ago. And what she said in this paper is that there is a 77% remission rate across all studies. 77% of people given conservative management have remission. So I'm not just quoting one paper, I'm quoting all of them that Adiola has kindly reviewed for me. That means that 23% of them have no remission. Another 20 who have remission recur. The treatment doesn't work. 50% of people, it comes back. Why would one want to do that? So how bad is Tom with his robot? Or his straight sticks as it initially was? And just remember, when we talk about not adequate treatment, the papers being quoted here were before the onset of the robot, as I saw the slides come up. They were before the onset of sentinel lymph node dissection. Who is doing pariotic lymphadenectomies in endometrial cancer now? Well, quite right, they didn't get pariotic lymphadenectomies. No women should get pariotic lymphadenectomies. Quite right, they didn't get pelvic lymphadenectomies. No women should unless you don't map at a sentinel lymph node dissection. And we demonstrated quite early on, and this is a relatively old paper now, but it was safe to operate on obese women. And I accept the argument that this was BMI of over 30, and I'm going to work up the BMIs as I go now. But we showed that we could quite safely do it, and we were getting lots of referrals from around the region. More recently, our friends in Guildford have looked at Class 3, that's BMI 40 or above, and they, like everyone else, had a number of patients in there. 13% of them had carcinosarcomas, clear cell carcinomas, and serous papillary tumours. Would you be treating those with conservative management? I don't think anyone would. There are still people with high-risk cancers in this group. 15% of them had grade 3 disease, and 1 in 5 had stage 2 disease. No one is advocating conservative management in these people, or is it okay just because you're fat? I'm going to talk a bit about that in a second. Guildford had women with atrial fibrillation, arthritis, asthma, diabetes, hypertension, coronary artery disease, hypothyroidism like anyone else. And you know what? I've got diabetes and hypertension and all those sort of things, and I jolly well hope that people would operate on me. And their complication rate was low, and I won't go into details, but you're able to do this in a centre with a proper ITU and with proper comorbidity assessments. And in fact, the surgery workup often picks up a lot of things and has got an extra healthcare benefit for these patients. So this is our fellow. He didn't fill out the questionnaire, Hannah, but I think I'm all right because I made him do something. He's called Rao Chatterjee. I asked him some time ago to do a paper from our series of BMIs 50 and above. Now, we are a cancer centre. We don't treat normally hyperplasia, grade 1, stage 1A, but it's amazing how many come our way when they've got a BMI of 50 and above. So we do some of those. And this is over a decade, so they're not a lot of patients every year. It's about 6 or 7. The mean weight was only 54.9 because it was all weighted towards the lower end of those BMIs, although we did have one of 82. 90% of them had some form of comorbidity, so I accept it was difficult to operate on them, but we got through it. We put them on the HDU. We sent them home majority of the time the next day. 21% didn't have an endometrioid tumour. They had high-grade tumours. They had serous papillary tumours. They had clear cell carcinomas. And who is advocating not operating on them? 15% had stage 1B or above. That isn't in the group of people we say is acceptable to have conservative treatment. And we had a few complications. This complication everyone knows about. I've shown it at about 4 meetings now. We videoed it. She then got a DVT. It wasn't because she was overweight. It was because the surgeon who's standing at the lectern was slack. I completely admit it. We had 1 uterine perforation. We still use a uterine manipulator. I know that's controversial in its own right. We had 3 vaginal lacerations bringing out a large uterus. In fact, we put that as down as part of the informed consent now because we think it's quite common to need a vaginal suture. We had 3 reactive conversions, and we had no medical complications. We didn't have any cardiac arrests. The only medical complication was the DVT, which I associate with the fact that I cut the common iliac vein. So, we all know about fake news. She's a pro at it. She can make up news as much as you like because she's learnt from the best. This is a friend of mine. He's called Andrew Jenkinson. He is an upper GI surgeon, and he works in the private sector on a Thursday evening in the next door theatre to me. And he's very well known because he's written a couple of books, and if you haven't read them, I would certainly read his first book, entitled Why We Eat, in brackets, Too Much, close brackets. And in his first paragraph, he says, if it was just a matter of calories in and calories out, we would all be 300 kilograms. Let's stop being prejudiced against these women because we know we can operate on them, or at least some people can. And failure to offer them conventional treatment is just a form of prejudice in my mind. Our theatres are full of men with BMIs of 50 plus having their prostates operated on. Why are we suddenly not wanting to operate on women? I would say that's sexual discrimination. I would also say that the Montgomery principle says we should be offering them conventional treatment because we know we can do it, and it is therefore the law that we offer it to them. But I take heart in knowing one thing, that my opponent, by the way, she's an influencer, she has nearly 1,000 followers on Twitter. And she says, I am a cancer surgeon, and I will continue to fight for my patients to receive best care. That's on World Cancer Day. And I know I'm filled with great pleasure to know that you would not offer them conservative surgery, and I know you would operate on them as a result of that comment. So, women with a BMI of over 50 and endometrial cancer should be managed conventionally, with surgery, with or without radiotherapy, with or without chemotherapy. They should have laparoscopic surgery. They should have sentinel lymph node dissection. And that is because traditional treatment in expert unit is safe. It's because traditional treatment is effective and works. It's because traditional treatment is required because they have less good prognosis than other people stage for stage. We know that conservative management is not applicable in most cases because they have high-grade serous carcinomas or clear cell carcinomas. We know that conservative management is associated with non-compliance. People don't have it. People don't turn up. We know that conservative management has many more complications because it has the complications of the hysterectomy that you've got to eventually have and the complications of the conservative management. And we know that conservative management doesn't work. Thank you very much.
I'm sure there'll be lots of questions.
Thank you. With the kind of mass uptake of Mounjaro, which is proving to be quite beneficial in terms of rapid weight loss, is obviously much more accessible for patients. Do you think that there is going to be a role for a period of conservative management with very active weight loss therapy prior to hysterectomy. Is that something that you would advocate for your definitely having surgery group, that actually for a period of time prior to that, you know, weight loss would be beneficial to then reduce their risks of surgery?
So in our expedited bariatric pathway that I talked about in the northeast, that's exactly what it wasn't Manjaro, but it was basically if we can put some hormones in them and help them lose weight, then we can make it a lot safer for them should they wish to have hysterectomy later. It's really important that when we're making that referral to bariatrics, because obviously Manjaro is one of those conditions that someone mentioned as well in bariatric units, as well as surgical procedures, and all the nutritional, psychological support they get as well. It's really important that the reason for referring for that is not to make it safer for surgery, but for the bariatric teams to consider surgery. I'll talk about Manjaro later, but the bariatric teams to consider the surgery. The reason for referral has to be that it's better for the patient's health. So we disassociate that. That's because obviously they're going to die of obesity-related disease. With regards to Manjaro, there are patients who are asking the exact same question because they maybe have even been considered for bariatric surgery, and the bariatric surgeons have said you're really high risk. So we need to think of something else, such as the balloon or a Manjaro. So I think there's certainly a role for a short-term treatment. The difficulty is that we don't have any long-term evidence of its safety or when to intervene, and certainly in the NHS recommendation is when you do stop drugs like Manjaro that you have follow-up. So who delivers that follow-up? If it's an oncology surgeon who decides that you should start it, I don't feel comfortable that I should be doing any kind of follow-up for that. So I don't know. Tom?
I take Manjaro. Those of you who know me know, but I used to be 20 kilograms heavier than I am now, and it's changed my life. But I'm a diabetic. Do I believe we should be offering these women everything? Yes. I'm not saying you shouldn't be helping them with weight loss drugs if it's appropriate, but managed by appropriate doctors. And I think the important thing, I mean, I can tell you as a patient, the important thing about taking these drugs is that, first of all, you've got to make sure you don't get dehydrated. You mustn't forget to drink water because it's very easy to do that. You've got to make sure you maintain your muscles. And, you know, I was in the pub the other day and I got a great big steak and I couldn't eat it and I was embarrassed. And I turned around to the waitress and said, look, I'm really sorry, I'm taking Manjaro. And she said, so am I. And she was about this thin. And I'm thinking, well, you know, I had a BMI of, you know, 34 or something, and, you know, I'm diabetic, type 1. And I should be taking it, and clearly this lady shouldn't. But I think these women do fall in the category of needing medical help. So, yeah, let's offer them everything.
Hi, Tom. It's Raj. I have listened to your debate many times, and you always, it's quite fascinating that how you debate. But the most important thing, I did raise my hand that, yes, BMI above 50, we should offer them surgery. However, why not we give a short gap? Because your theatre list, if everybody is referred to for a robotic surgery, the patient will stand for a queue from John O'Groats to down in the south. So I do not want that. So for them, I think for a short interval, 6 months trial of trying to utilize all these available treatment should be a better option, and that would be surgically much better outcome in terms of the complications. They are not going to have a surgery under Mr. Tom In, though. Thank you.
Well, Raj, in answer to that question, you can go and see Nithya because she'll do it too.
Next year we're going to be having a debate, should these women be operated on in cancer units versus cancer centres? And
but in answer to your question, is it doesn't work. They'll come back 6 months later and they'll be exactly the same weight. But not necessarily. 2% of them will have lost significant weight. 2%.
Thank you. I wonder if those people who work in cancer centres who are suggesting that women can have conservative treatment, and referring them back to their cancer units, give any thought to the poor SAPs at the cancer unit who then has to try and get the Mirena in and do the recurrent biopsies. My knees are not what they used to be from putting Mirenas and taking biopsies from people with body mass index of 50 plus.
There are many patients who've been referred to certainly our centre that I've held on to because for that very reason, although I recognise that's been my unit colleagues who have done the initial investigation and put the first Mirena in and started all the treatments. So I don't think it's a you or us kind of situation. I think it's very much a shared thing, and we share the responsibility and we share the care for the patients. And sometimes patients will intermittently see us in a centre just to have the discussion about is now the right time to have the surgery or can we carry on? I don't know if you do it differently, Tom. Do you your follow-ups?
So we don't actually have a unit within our centre. So I mean, I agree with everything you said. I sympathise with everyone in the pathway. I think that's not a reason, though, to prejudice against someone. And I think, these women have a genuine illness, and we have to treat them with respect. And I think everyone in the room would agree with that. So just because we don't like it because it's challenging doesn't mean that we shouldn't offer them the best treatment we possibly can. And that's said without a tongue in my cheek. I believe it.
Hi, thanks for a great debate from both of you. So I'm mainly going to address this to Tom. The conservative management, I tend to agree more for you, but the problem isn't so often the gynae surgeon, it's everyone else they speak to. So when you say, we'll do your operation, then you're going to see an anaesthetist and everyone else is saying, oh no, you're going to die from your operation. It's not just because Mrs. Sungup is doing the operation. It's all your comorbidities and everything. And then they get out the risk calculators and they give them the risks and everything. And then a patient, I've had quite a few patients come back to me, you've got a robot, and I thought, great, we're going to be able to do all this now. And several patients have said, well, I've spoken to your anaesthetist and he says that I'll die from the operation, so I'm not going to have it, And that is a real problem I'm finding now. The other thing is, when do you reach a BMI when you do stop? What is your record?
So the record's 82. I can't remember the weight. I remember it wasn't actually my patient, it was Marielle's, and we agreed that we were going to do it together. And I was too tired assisting her after the first hour, and she assisted me for the second hour. I think, buddy operating is important in these situations. I don't think there's a point where you stop. My anaesthetist talks about the small round woman compared to the tall pear-shaped woman, and we know that there's more than just your particular case. And that complication I told you about, there were a number of big mistakes in that. First of all, we put her on the table at 4 o'clock on a Friday, which was the wrong thing to have done. 2, she'd had an umbilical hernia repair with mesh and had a previous bowel perforation. And we were expecting much worse than what we found. And when we came in and saw that it was actually an easy operation, there was a bit of relaxation, and we probably shouldn't have relaxed. It's not my proudest moment. I think you've seen the video. But I do show it because I think it's important to learn from these lessons. So there isn't any upper limit, but you obviously have to take into account all the other things. Someone who's got an active pulmonary embolus might defer a bit. I don't know.
So do you, it comes back to your comment you just made about, do you remember that document from a college scientific impact paper about obesity and endometrial cancer, and arguing about centralisation of all surgical services for endometrial cancer, not necessarily with a cancer centre.
The one from 1999, that one.
Quite an old document.
Yep.
But they're saying about high volume operators should be the people who are operating on these patients.
Well, I don't think we would disagree there either. I mean, there's a good paper from Jason Wright where he's looked at the cost of surgery in high volume centres compared to non-high volume centres. And certainly if you want a robot, you've got to be a high volume centre, because otherwise it's not cost effective.
It also complies with GIRFT as well, getting it right first time.
Yeah.
Basically says that.
Mm.
Thank you.
Thank you, both of you. My question is in relation to conservative management. We've had a flurry of patients with VTE, particularly those on Megace and high-dose progesterone. And it's a constant battle with the medics. They present with bleeding because they're put on anticoagulants, and then we stop, start. What's your experience with...
Super difficult, isn't it? It's really difficult because they've got other risk factors for the VTE, not just the progestins. So you have to treat them, and then Renocoil. It's fine, it works well, but it usually works better if you put some oral progestins as well. So there's no right or wrong. I don't think it's an easy one. I don't have any advice for that. There's no one size fits all.
Thank you. There are many women with morbidly obese, postmenopausal, who are deemed not fit, followed up in units. What is the rationale behind the follow-up with endometrial surveillance? Like, if we know that most of them will be like grade 1, they regress, they may recur again, and if the situation doesn't change, the BMI is not low, is there any role for a symptomatic-led intervention rather than repeating the endometrial biopsy every 6 months or 1 year? Thank you.
Well, although there's a difference in recommendations, it would tend to be that if they haven't responded, or if they haven't, or they're progressing, that we should consider definitive surgery. That's for sure. But then the difficulty is if they're still super high risk. So if they're maintain high risk, that's when you've got to use that window we talked about just now to optimise them. So it's not just put the hormones in and forget about them. It's what can we do? So in our MDT, we actively say refer to bariatrics, because that's the only thing that's going to get them to a point when they do recur and progress, as Thomas said, to the point that they're fit enough for the surgery.
Would we consider imaging, follow-up with imaging at some stage, like every year, for example? Because, with the grading, it's not going to make a difference, like in the...
Yeah, so it tends to be in the early part of the follow-up, you kind of follow them up every 3 to 6 monthly, and then as years progress, yearly. I had a patient who I followed up for 8 years before I ended up doing a hysterectomy, and I only did a hysterectomy because she eventually she was fine. She'd lost weight, and she actually had decided she was not in a relationship. She was nulliparous, but she decided actually that she was now fit enough and mentally prepared enough to undergo the hysterectomy. So there's other things we haven't even touched upon the psychology of it.
Just the last question, thanks.
Thank you. Thank you for an excellent debate presentation from both of you. I'm going to go slightly rogue and extend this to endometrial hyperplasia with atypia. Do you take a different view?
Well, I mean, if you take the crux of my argument is that you should be offering standard management, then I've got to continue that. I mean, I've forgotten the figure because everyone quotes a different figure, but my understanding is that 30% of people with endometrial hyperplasia will have cancer in the final specimen, and 30% of people will develop cancer if they haven't got it already. So I can't argue that you have to offer them standard treatment and then say it's something different for hyperplasia. So I would stick by my guns and say, no, I wouldn't want to give those dangerous thromboembolic causing progesterones. Nithya wants to give them.
The other thing is, Tia, is that we know that if you sample the obese lady and it comes like hyperplasia, if you do the hysterectomy exactly as Tom said, you're going to find the cancer. And I always remember once being called into a unit leads theatre because they were having difficulty finishing this hysterectomy. And it was really tricky. It was really difficult. The patient was morbidly obese. And I just thought, well, she's got hyperplasia. She's definitely going to have a cancer. And if we decide not to do the hysterectomy for whatever reason, abandon it, she's committed to perhaps never knowing that she's got cancer. We did the hysterectomy, finished it, and of course she had a cancer. So I think the difficulty with these morbidly obese patients is that most likely there's going to be some cancer associated with them. So the standard would be for those patients if you can, but the lifestyle factors should also be addressed.
Just before I ask you to re-vote, just out of my own interest, who here refers their patients to cancer centre based on BMI, and otherwise they would operate at unit level. So if it was just for the BMI, are people sending to centre? Just out of interest, what BMI would you send out? 50. Anybody else? Just because we don't have access to those. Okay. And does that mean everybody else is doing it in your units?
No, we have a bariatric service.
Okay.
So, we've negotiated a portion of their capacity.
So just again, show of hands, if you're in a cancer unit or unit surgeon, who's operating on BMIs in excess of 50? Okay, so about half. Okay, that's just for my interest, really. So a fantastic debate. Thank you so much. So final show of hands then. So for the motion, we should be offering conservative management for women with a BMI over 50. Show of hands. So for the motion, so conservative management, and then surgical management. I think you've swayed them, Tom. I think you've swayed them. Thank you.